Okay. So my name is Frances. I think I've met many of you folks in my classes. And I'm going to be talking about documentation from a private practice perspective and also speaking to a few notes about working with the LGBTQIA plus folks and substance use related considerations. So, graduate of the program, love it. So you know a little bit about me. I've been working in a fully remote private practice since about June 2020. If anybody here is a historian, you know what happened a couple months before that. And I currently carry a caseload of about 60 clients. It is important to note, just as I'm talking about this, our amazing presenters have talked about that they're working from a perspective of a lot of folks dealing with a lot of billing for Medi-Cal and such. I've only recently started picking up folks with insurance, so some of my adjustments are still being made. Sorry, but I need to move some stuff around. So 2/3 of my clients are cash pay, which means that gives me some real flexibility in regarding diagnosis and medical necessity. Now, that doesn't mean that I exploit people and keep people around to hang out and chit chat or see them and not do clinical work. What it means is that, frankly, I tend to be very, very conservative in my diagnoses because I think that the DSM has a lot of issues itself. And that I also, on the flip side of that, just because clients may have money to keep me as a therapist doesn't mean that I will keep them. So for instance, if somebody has multiple late cancellations and they just don't care and they'll just keep paying me, that doesn't mean I'll keep them. I will terminate them, and I have that documented. But that's just like something to note from a like my perspective and orientation. So for paperwork, Myra covered a lot of this in intake. What does standard practice look like for my practice? I am full on extra. I will do more than less. My paperwork includes informed consent for telehealth, practice policies, and annually, if I have established clients that have been around for a while, I send an update every year if I have to add anything. I have some clients I've been seeing now since 2017. Some of them biweekly, every 2 weeks. We're still doing good work. Some of them would still meet medical necessity if they were well, they still do if they were going through insurance, but those folks are just paying cash pay rates. Also include privacy practices, my cancellation policies, because I am a stickler for it. If you've had me for a class, we've had that discussion. I also include schedule of fees. We are required now as practitioners to provide a good faith estimate, which is important, which is interesting because I've gone to a bunch of medical appointments and stuff myself, and I'm not getting this. So people are out of compliance everywhere with this. Also new this year for LMFTs, we have to, if we're going to opt out of Medicare, we have to provide that information as well for our older folks. Emergency contact for telehealth services, that's another piece that has to be provided and documented, and that includes local emergency resources. The clientele that I see ranges from as far north as Eureka to as far south as San Diego. I go as far east as Bishop and all the way over to Carmel. So I have to kind of establish what the emergency situations are in those spots, and it's all documented. Also, all of my clients upon intake, I send them a standard intake questionnaire, which includes a risk assessment history that is then reviewed in the intake session. I am also, I'm really big on ACEs. That's the Adverse Childhood Experiences Scale. And I give the rundown on that to clients because I think that's an important part of them understanding what they could be predisposed to from chronic health perspectives. GAD-7 has to do with measuring anxiety. PHQ-9 has to do with measuring depression symptoms. Supplemental inventories may include PTSD checklists. For some of my transgender folks, the transgender self-evaluation has to do specifically with people who may have issues related to their voice, just kind of assessing for that. That doesn't mean I send it out to all of my trans folks, but it's something that's possible. That could be helpful later in treatment goals and providing connections to gender affirming care, those kind of things. And then with folks that are looking for help with their substance use or their relationship with substances, there are a couple of different substance use questionnaires that are helpful. There's also specific inventories that you can send out in questionnaires for couples and adolescents. With my private practice, specifically those that are paying cash pay, I tell clients, like, I'm going to send you a boatload of paperwork. Don't get overwhelmed. But the more they get done on the front end so I can review it, the more I can make use of our sessions so I can review it, have quite a bit of my assessment already kind of done, and then bam, 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 roll through it and get through and actually have like my documentation kind of tied up. And I'll get to that in a moment, why I find that that's so important. Also, when I get nervous, I talk fast. So Erin, I'm going to look at you because you're in the corner. So if you can just be like, whoa, if necessary. Okay, awesome. Okay, so private practice. First of all, full disclosure, never wanted to do it. I didn't want to have to be responsible for maintaining my own calendar. I did not want to have to communicate with clients outside of just bring them into my office, tell me about all of your traumas and your terrible feelings, and then don't talk to me until the next time you come in. I did not want any of the responsibility. Then the pandemic happened, and then things like Simple Practice rolled along, and it became a little more doable to manage all of these things. And frankly, you make more money when all is said and done. It does require a lot of use of boundaries, both for yourself and others, but it's cool for me now. So what does that mean? Here's my preference for documentation in private practice. First contact, a detailed psychosocial assessment. As I mentioned, I try and do quite a bit of that. I front load that with all of the questions and stuff from folks. I tell them to please have it done a day prior to our first meeting so I can review it. Do the psychosocial assessment, first contact. After that, I transition to a SOAP note, which is, it sounds like pretty similar to what Lauren was describing with the note that she was going through. And then, boy, back in the day, we didn't have auto-populate. It's so awesome now. Now things auto-populate. Kids don't even know how good you have it. I say that lovingly. Boy, was it rough. So anyways, I use a SOAP note. Any question? Was there a question or? Oh, okay. Second session is when I complete a treatment plan, and then Simple Practice, which is worth its weight in gold, lets you know when you need to update that every 90 days. The truth of the matter is no one checks this stuff but me. We'll get to that later. So treatment plans can be as simple or as complex as you want them. But mine tend to follow what we've already seen from what Renee talked about and what Lauren talked about in terms of kind of the way that they're structured. And I am fully on board with have the client create a buy-in. And what I love about some of my longer term clients is because I take detailed notes and because we have developed the treatment plan together, while they can't see their progress sometimes, because sometimes progress takes a while, I can go back and go, okay, well, you had a little bit of panic today when you had to talk to that doctor because now you're an ICU nurse. But do you remember when you used to panic about walking into your nursing class 5 years ago? So like I can through documentation and this development of the treatment plan show the growth, but that doesn't mean that the anxiety goes away. So treatment plans as complex or as simple as you want. There it is. I also document all emails. I print emails to PDF, upload them. I try and keep emails to a minimal interaction. Any letters that I have to provide to clients, including intent to close letters, I upload them. I also make it really clear to clients that I don't do text messaging for treatment. That does not necessarily stop some clients from texting you. So I will transcribe my text messages into a clinical, like, kind of case note and put it in there as well. Because I just want to make sure that I have all of that in there. And then I can go back and be like, hey, I don't do treatment via text message, or you knew that I said we need to see each other once a month to stay active, and you haven't been scheduling, so here's why we're terminating. So that's that. Where are we on time? Okay. I also do a discharge summary when we're done. And as I mentioned, when you don't bill insurance, you have more freedom, but you also need to abide by a standard of care, and that includes getting documentation done in a timely manner. So some LGBTQ plus considerations. Think about your intake paperwork: legal name, preferred name. They're going to have to put their legal name on stuff. That does not mean that has to be the name that pops up every time it sends them a reminder text to fill out paperwork. So I think that that's something that we're getting better about, but we really need to pay attention to. And it's not, and by the way, the legal name and preferred name is not just for folks who are changing their names because of gender identity stuff. This issue has come up with one of my clients who didn't find out her legal name until she was in her 30s and found out she was adopted, but they had never really changed her name. So imagine being in your 30s and 40s and, like, she's always gone by this one name. She finds out later, but, like, she hasn't gone through the process of changing it. She just wants to use her name. So we need to pay attention to that. We also need to pay attention to pronouns, and that includes if you are working with folks who are transitioning their name or pronoun while they're in treatment with you. So you may have to make some of these changes in your documentation, including your stuff on the back end, including with folks you're working with. So that's something to think about. Also, we need to think about, in considerations, I threw it in here under the LGBT stuff, but you can have straight cisgender folks too who have multiple partners. So when we talk about partners, we need to think about, I use the word partner and not spouse, but people may have multiple partners. So when we're talking about people, about what their relationship dynamics look like, we need to keep in mind now that families look different, relationships look different, and that piece needs to be addressed. So pronouns, partners, children. We need to think about when we're asking people about their children. Because if we say, okay, well, do you have, tell me about your kids, how many boys, how many girls? What if they have trans children? What if they have non-binary children? There's things like that we need to keep in mind too, right? What if they have adoptive children? So again, I'm using it under this umbrella of LGBT, but really I'm just thinking of anything other than heteronormative. We also, with diagnosis, want to think about who's going to see that diagnosis, including insurance companies, including work. If, like, sometimes like you want to get a super bill to get reimbursement, and if they see a diagnosis on there, sometimes parents, if it's a minor. Frankly, in the world we're living in, I'm getting real a little scared about writing down some diagnosis for people with the current political situations that are going on, as both a parent and as a practitioner. If you need more clarification on that, I encourage you to seek out folks in the LGBT community, if they have the space to do the emotional labor to provide that for you, or do your own research, but it's a scary time. So we need to think about, when you're writing down diagnoses related to LGBT stuff, if that needs to be on there, including, like, for instance, gender dysphoria. If they're doing gender affirming things, are they really dysphoric anymore? So those kind of situations coming up. Also, is a diagnosis even necessary? Like I said, is it required in the setting you're working in? Can you just say you're working on generalized anxiety? And again, maybe I'm kind of, some of these people I'm doing cash pay. If somebody's got generalized anxiety, I'm going to write down generalized anxiety. They definitely have it. We will work on that. I am going to keep their trans stuff off the record. Your professional person signing off on you may feel different. Substance use consideration. Think about your intake paperwork. Are you using assessments? It's a whole lot easier to get that stuff ahead of time than to sit in session and then ask them, have you used blah, 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 blah. So have some sort of assessment prior is helpful. Also, again, think about the diagnosis. Who's going to see it? Is one necessary in the context of where you're working? If you're working in a substance use clinic, it's necessary. If somebody is really just exploring their relationship with alcohol and trying to work that out with you, but they got a whole host of other things, do they really need 5 or 6 diagnoses in that one too? If they're using substances to cope with their extensive sexual trauma or the fact they've been ostracized from their family and their religion because they're gay, you know what I mean? Like, let's prioritize, because I'm billing insurance for 17 clients. I only need 2 diagnoses. You only need 1, you need a primary. So again, thinking about if you need it. Also, how often are you assessing for substance use? I ask every single time. Hey, where are we at? And then the more you can come at it less judgmentally, the better. So my client today, I was like, hey, where are we at? And she was like, you know what? She just had a relationship fall through. She was like, Valentine's Day was hard. And then I walked through the baby section at Target. And I was like, all right, cool. So what's the plan this weekend? And this is where I get to this part about treatment planning. Not everybody who is using substances to a negative degree wants to be sober. So we need to think about moderation. We need to think about harm reduction. So an example here, this client will report and demonstrate no instances of problematic use of alcohol or other substances 2 times or more consecutive weeks. For her, she was using alcohol and there was a lot of sexual assault that was wrapped up in that because of a series of things. So I said, hey, did we find ourselves in any situations? No. Okay, cool. Did you drive drunk? Yeah, once. All right. This week, we're not doing that, right? Nope, we're not doing that. She's like, but I'm going to go out this weekend because I'm going to try and stop drinking on Monday again. Okay, cool. She's like, honest. She's like, I'm going to be doing mimosas at brunch. Okay, cool. I said, can you have a glass of water between every mimosa? I can try that. Awesome. But if we come at that, like with judgment, if we come at that with you're failing, she's going to turn all that off. Not going to be engaged, not going to be in it. Right. So those are the considerations. Lastly, creating accountability. How do you stick to documentation? How do you stick to documentation timelines when no one is looking and you get paid the same day? Figure it out. For me, it's I never go into the weekend with unfinished business. I've gotten into a really nice routine where I just get it done, and it's because of it's habits that I've established over the last 10 years. I have also worked with people who have not done notes for years. I think that those same folks should not be doing this business. I think that it is wildly unethical. It is incredibly illegal. It is very, very damaging, and you do not deserve to be trusted with people's energy, and you should not be getting their money. So I feel like I am robbing people if my documentation's not done. That's my guilt complex. So I get my documentation done. But that's something to think about. Everybody wants to go into private practice, but no, literally no one's looking. No one would know. Not going to know, and you're getting paid. So I tend to use no more than 72 hours. I prefer to just have a clean slate going into the next day. And I always audit myself every day, every work day. And that's it.